Hi, this is Diagnosis Bona Croatia Bona. We continue nephrology, and today we'll talk about proteinuria. Healthy people can excrete some protein in the urine, which can vary from day to day and hour to hour. Hence, the value of collecting is over 24 hours. The amount of protein in the urine is normally less than 100 for 24 hours, and greater than 300 is abnormal for kids as well as for adults. Today we will take some of this condition with proteinuria, and so let's start with nephrotic syndrome. And last time we talked about nephritic syndrome with hematuria, and of course for many conditions it could be proteinuria and hematuria, but in this case we talk about when even there is such condition, proteinuria will be greater. Nephrotic syndrome. The nephrotic syndrome is caused by renal disease that increases the permeability across the glomerular filtration barrier. It's classically characterized by four clinical features: nephrotic range proteinuria, hypoalbuminemia, edema, and hyperlipidemia. The first condition is minimal change disease. Their nephrotic syndrome generally present with edema and often occurs after an inciting event such as an upper respiratory infection or insect bite. Typically, pubertal edema is noted first. The edema is gravity dependent, and thus over the day pubertal edema decreases while edema of lower extremities increases. Dyspnoea, waxy pallor, and diagnosis: measure 24 hours urine protein or spot urine protein to creatinine ratio to confirm the diagnosis. And also you can see minor changes without immune deposition on light microscopy and podocytes with missing feed on electronic microscopy. Treatment. The best initial management is corticosteroid treatment. Diuretics are rarely indicated and should be used with extreme care. Occasionally, aspirin may be used to prevent clotting. However, the main strategy is mobilization and avoidance of dehydration. About 70% of children have relapses, but most of these will have ceased relapsing by 18 years of age. Complications include infection, thromboembolism, and hypovolemia, and it's very rare for steroid-sensitive minimal change disease to progress to chronic renal failure. Focal segmental glomerulosclerosis is a histological lesion rather than a disease, and it's the most common form for primary or idiopathic nephropathy in adults. Complex manifestations of FCGS include hematuria, increased BUN, creatinine ratio and lipids, hyperalbuminemia, hypercoagulability, heavy proteinuria, and lipiduria. Histology typically shows focal segmental immune deposits with scarring and shrinking of the kidney. Treatment: salt restriction, diuretics, statins for hyperlipidemia, and heparin and coumadin for hypercoagulability. Prednisone as initial treatment, and with cytotoxics are more helpful with refractory cases. Prognosis: most progresses to end-stage chronic renal failure over 5 to 10 years. Membranous nephropathy is among the most common cause of the nephrotic syndrome in non-diabetic adults. This condition can be either idiopathic or secondary to drugs like gold, penicillamine, and diseases such as hepatitis B and C, syphilis, malaria, autoimmune disease, and cancer, except Hodgkin's disease. Electronic microscope shows immune complex and granular deposits, IgG and C3, on the GBM with spike and dome appearance. GFR is normal, but the urinary loss of antithrombin-3 may result in hypercoagulability. Treatment: salt restriction, ICE inhibitors for hypertension and persistent proteinuria, statins for hyperlipidemia, heparin and coumadin for hypercoagulability. Steroids plus cytotoxics may help in severe disease, and prognosis 80% can be stable and 20% may progress. Preeclampsia. Most common features include new onset hypertension after 20 weeks of gestation and proteinuria. This condition predisposes to the prematurity and intrauterine growth retardation of the fetus, eclampsia, placenta abruption, intra-abdominal and intracerebral, cardiac failure, multi-organ failure. Risk factors: women older 40 years old, nulliparity, multiple pregnancy, BMI greater than 30, diabetes mellitus, pregnancy interval of more than 10 years, family history, previous history of preeclampsia, previous high blood pressure or renal disease. Clinical features: hypertension, proteinuria, headache, visual disturbance, papilledema, epigastric pain, and hyperreflexia. Diagnosis: elevated liver function tests, severe proteinuria, oliguria, elevated creatinine, thrombocytopenia, intrauterine growth restriction, or oligohydramnios. And it also could be HELLP syndrome. It occurs in about 10% of patients with preeclampsia. HELLP syndrome is hemolysis, elevated LFTs, liver function tests, and low platelets. Treatment: magnesium sulfate, and for severe preeclampsia after 32 weeks is delivery. Expired tetracycline has caused Fanconi syndrome. It's disorder of the proximal tubule of the kidney. This leads to defective transport of certain substances, including glucose, amino acid, sodium, potassium, phosphate, uric acid, and bicarbonate. And characteristic findings include glucosuria, phosphaturia, proteinuria, polyuria, dehydration, hypercalciuria, and hypokalemia. Bicarbonate fasting can lead to renal tubular acidosis, while phosphate fasting can disrupt vitamin D metabolism and bone mineralization. This can result in rickets or impaired growth in kids, osteomalacia, osteoporosis, and pathologic fractures in adults. The primary therapy for Fanconi syndrome is to treat the underlying cause and replace substances waste in the urine. Fluids and electrolytes are administered orally or parenterally to prevent dehydration resulting from polyuria. Diabetes mellitus. Diabetes leads to macrovascular and microvascular disease. Macrovascular disease include coronary artery disease, stroke, and peripheral vascular disease. It's a leading cause of limb amputation. Microvascular disease include retinopathy, a leading cause of blindness, nephropathy, a leading cause of end-stage renal failure, and peripheral neuropathy, sensory and automatic. Diabetes also leads to an increased incidence of infections. Clinical features are polyuria, polydipsia, polyphagia. So it's a pee a lot, drink a lot, and eat a lot. Weight loss as a result of extensive urination or blurry vision. Diabetes is defined as a glucose level greater than or equal to 126 mg per deciliter after an overnight fast on 2 separate occasions, or a random glucose level greater than 200 mg per deciliter, or a hemoglobin A1c level of greater than or equal to 6.5% on 2 separate occasions. The goal are to keep postprandial glucose level less than 180 mg per deciliter and fasting glucose level 70 to 130 mg per deciliter. Treatment for DM1 is insulin, for DM2 is weight loss, because it may reduce glucose levels by reducing insulin resistance. Medications. The first medication is usually metformin. Other agents include insulin secretagogues, thiazolidines, alpha-glucose inhibitors, GLP-1 agonists, and amylin analogs. Multiple myeloma is characterized by the presence of paraprotein in the serum, produced by abnormal proliferating plasma cells, and Benz-Jones protein, comprising light chain components of immunoglobulins in the urine, and you can find them by immunoelectrophoresis. Clinical features: it's a bone destruction, bone pain, vertebral ribs, punched out, lithic bone lesions, pathological fractures, and renal impairment. Diagnosis: presence of paraprotein in the serum and Benz-Jones protein in the urine, calcium elevation greater than 10.5 mg per deciliter, renal insufficiency, anemia, bone lesions. Skeletal survey will show you lytic lesions easily seen on the skull. Bone marrow aspirate, it will be greater than 10% of plasma cell in the bone marrow. Treatment: chemo, immunomodulator, proteasome inhibitors, steroids for young people, stem cell transplantation, and palliative care for elderly. So thank you very much for watching, and see you next time. Bye bye.